career was in the BC Center Cancer Agency, where she performed retrospective exposure assessment for occupational and epidemiological studies in British Columbia and internationally, including an international study of occupational workers conducted by the International Agency for Research on Cancer. So between 1997 and 2004, she worked at WorkSafe, first as a policy analyst working on both occupational health and safety regulation and occupational disease compensation policies, and taking on responsibility for creating and implementing systematic process for research, knowledge transfer, and strategic initiatives. Since 2006, when she has consulted for a number of organizations, including the Canadian Mesothelioma Foundation, the UBC Partnership for Work, Health and Safety, Occupational Cancer Research Center in Toronto, Alberta, Labour in Edmonton, the Safety Net Center for Occupational Health and Safety Research at St. John's, the BC Center for Disease Control, as well as the National Collaborating Center for Environmental Health and Paris, Canada, the International Agency for Research on Cancer, and the BC Center Agency. Since 2014, she has provided pro bono assistance to workers diagnosed with occupational diseases or their surviving spouses, helping to identify possible sources of exposure and working with them to create comprehensive occupational histories to support their claims for workers' compensation.
Thank you, everybody, and thank you for the invitation. What I'm going to be talking about today has come from the work that I've done in the last 4 or 5 years doing the pro bono work for claimants or their spouses who are filing claims on behalf of their deceased spouse. So what I am going to do is, because we have a very diverse audience, I know that there are students in the audience who have likely not been introduced or exposed to what the compensation system is. I'm going to briefly touch on some aspects of the workers' compensation system. If there is interest, or if I can't answer any questions that you may have at the end, there is a seminar being put on next week. It's a webinar through the Occupational Cancer Research Center in Ontario, and it'll be given by Catherine Lapel. She'll be talking about medical legal issues with respect to workers' compensation. So I'll make sure that link gets shared with everybody. Can everybody hear me? Okay, sorry. It's a bit awkward holding the mic. Okay, so let's get started. How I've structured the presentation today is I'm going to just briefly introduce a couple of key concepts, and then I'm going to talk about why this is an important issue, and then dive into kind of the 4 key elements of building, determining entitlement, and then building sort of leading towards building an occupational history. And I'm juggling 2 screens here, so bear with me. That did not work. Okay. How do I get this to move forward? There we go. Got it. Okay. So starting with a definition of what we mean by occupational disease. So if you go on the internet, an occupational disease is defined as a disease resulting from the conditions of a person's work or trade or occupation. What we're talking about today is, or are diseases that are recognized by law or policy. In British Columbia, these are covered under the Workers' Compensation Act, specifically Section 6, 6.1, and 7, which is the noise-induced hearing loss regs. Or provisions, sorry, and then Schedule B, which is an attachment or a schedule to the Act, which lists occupations and diseases that are recognized under the Act. The other place that there is information on which types of occupational diseases are recognized is in Chapter 4 of the Rehabilitation Services and Claims Manual. And in the context of occupational disease that's recognized by workers' comp, it includes disablement resulting from exposure to contamination. Okay. second thing I wanted to define, or just make sure that we kind of have an understanding of, is what I mean when I talk about a long latency disease. This is an image that I borrowed from a report that's coming out on Monday, being published by the Occupational Cancer Research Center, which basically illustrates, they were using this to illustrate how they performed the analyses that they were doing, where they looked at the risk of cancer in populations in 2011 and then backed out kind of the period, the risk exposure period, where someone who was diagnosed with cancer in 2011 would have likely had exposure for that would have contributed to the development of a solid tumor or lymphatic or hematopoietic cancers. Okay. So why are these cases important? One of the biggest reasons is that cancer is the leading cause of death in Canada. And what this slide shows is on the left, sorry, just making sure that your left and my left. So on the left is the number of new cancer cases in Canada. And on the right is a figure from the Canadian Cancer Society that's looking at the lifetime probability of developing cancer. What you can see from looking at the figure on the left is that the number of new cases is climbing. This figure it ends in 2016, but as of what's available on the Canadian Cancer Society's website, they're estimating that there will be over 220,000 new cases of cancer diagnosed this year. And in addition, there'll be over 82,000 cancer deaths happening in 2019. In terms of the lifetime probability of developing cancer, it's estimated that 1 in 2 Canadians will develop cancer in their lifetime, and 1 in 4 will die of the disease. So the second reason is that exposure is widespread. This slide, the information on this slide and on the next slide also comes from the Occupational Cancer Research Center. These are tables and data from a report, the report that's coming out on Monday. And essentially what it shows are occupational exposure estimates or the number of exposed Canadians in the middle column. On the very left-hand column is the carcinogens. They focused the study looking at 13 carcinogens that Canadians are exposed to. And then an estimate of the annual number of cancers that are diagnosed. And the number in the bracket is the attributable risk. So looking at, for example, the ultraviolet radiation, there's over 1.5 million Canadians who are exposed. They are estimating that the annual number of cancers that are diagnosed that are related to that exposure is 4,600 non-melanoma skin cancers, and that accounts for 6.3% of the risk. Okay, so this is just the remaining list of carcinogens on that list, and I'm not going to go into a lot of detail. The only other thing I wanted to comment on is that the prevalence of exposure and these estimates were generated. It was a work that was done with the Occupational Cancer Research Center as well as with CAREX Canada. Okay, so the third reason is that the occupational disease claims in Canada, this is looking from 2009 to 2017, have exceeded the number of claims for traumatic injuries. So what this graph is showing, and I realize it's on it has cut it off, sorry about that. So the red lines represent the Canadian numbers, and the blue lines are BC's numbers. If I were to also superimpose Ontario's numbers on there, you would see that a lot of these numbers are being driven by what's happening in Ontario. So the solid line is represents compensated fatal claims for for cancers, and then the dashed line is the traumatic injuries. And BC, you sort of see that the trend is similar, but there's a tighter connection between, or less of a difference between the traumatic injury line and the cancer line. Okay, so next reason is that why this is important is the actual burden is not represented in the claims. Again, this is information from the Occupational Cancer Research Center, and I just want to draw your attention to the two boxes on the left-hand side. They calculated the compensation rate by dividing the average fatal claims between 2011 and 2014 by the estimated number of fatal cancers. And in terms of lung cancers, they're estimating that the compensation rate is approximately 5%. With mesotheliomas, where the link between exposure and outcome is much more clear, the compensation rate is about 61%. Ideally, that should be 100 when you've got something that is a single cause of it. BC is doing a bit better. I didn't have the data to be able to do a similar calculation here, but I know that Mika has done work on it, and that there was some research that's come out of UBC where the disconnect, or the difference between the numbers diagnosed and the numbers compensated is a little bit closer. Okay. And then finally, the last thing I just wanted to comment on in relation to this is, second to last actually, sorry, is just to give you a sense of kind of what the claims look like. So the blue columns, the blue column on the very left is the total number of fatal claims. So we've got Canada, BC, and Ontario. Looking at the total number of fatal claims, the next bar over, the light blue, is the total number of mesothelioma claims. And then there's lost time claims and lost time mesothelioma. So what you can see is that in the fatal claims, approximately half or more are due to asbestos-related claims. And then finally, I wanted to just acknowledge that the reason that these cases are important is that there's a huge economic and human cost. There's some work that was done by Emile Tompa et al. At the Institute for Work and Health, and one of the findings was that on average, the costs of these cases, for per person, cost of these cases is enormous, and then the total cost to the economy is also huge. We're looking at around 1.9 billion for lung cancer and 480 million for mesothelioma. Okay, so jumping a little bit further forward and talking about why these cases are challenging. What makes these cases challenging is that when they're being adjudicated, the adjudicator needs to collect evidence of exposure and to not only show medical causation, but also they have to meet the test of legal causation. This is where I'm going to just briefly touch on what the legal test of causation is here in BC. And as I said, there will be a seminar or webinar next week, so I encourage you to tune into that if you want more information. So in BC, there are 3 key requirements, and what I have highlighted here in this particular slide in red are the key requirements. So the first one is, does the worker suffer from an occupational disease? The second one is the worker disabled from earning full wages? And thirdly, is the disease due to the nature of employment? And that's the question where they're getting at kind of medical causation. The diagnosis, just to sort of give you some context about how these claims are adjudicated, the diagnosis must be confirmed by a medical professional. And in the other thing that's noted at the bottom of this provision is that even if a worker is not disabled from earning full wages, he or she can receive a health care benefit under this provision. So in terms of causation, there's 2 policy avenues that causation is determined. One is by presumption, and then the other is by policy, where there is no presumption. So I've included on this slide the language from the Act, which is under Section 6.3, which governs the adjudication of claims under the presumption that there is a presumption of a relationship between the disease and an exposure. And then I've included a couple of examples from Schedule B. So what I've highlighted here is one key point that and this is it plays into why these again are so challenging when you're looking at cancer claims. They have one of the tests for legal entitlement is that the worker had to be employed in that process or technically exposed, in other words, exposed at or immediately before the date of disablement. So thinking about that that slide where I was illustrating latency, if the diagnosis doesn't happen until after retirement or kind of a delay between employment and the diagnosis for other reasons, then this particular section of the Act doesn't kick in, and then the claim is adjudicated on its own merits. So what I wanted to do is to walk you through kind of how the question of entitlement is pieced together. And it's basically a puzzle or a bit of a detective game or detective problem. Game is the wrong word. So at the center of the puzzle, I've placed the question of entitlement. Like, so if a worker is diagnosed with a particular illness or disease, are they entitled to compensation? So the first question that needs to be answered is diagnosis. They need to have been diagnosed, as I said, by a medical professional with a disease. The second is the question of exposure. So, and then kind of tying in with what I was just saying about this, the latency issue is how do you establish that a worker had sufficient exposure to cause the disease when the exposures happened years or decades in the past? And how do you come up with an estimate of exposure if there is no data? So if there are no historical records or there's no monitoring data, how do you come up with an estimate? The other thing is that exposure doesn't happen in a vacuum. You've got to sort of think about the one individual who's working in the context of a team of workers, and there are other workers who are exposed, and their exposure is, or what they are doing around them can contribute to exposure. And then how do you factor in multiple exposures that may have played a role? And then how do you factor in confounding exposure like smoking? So one of the, actually I'll hold that thought. So the next part of the puzzle is establishing the question of general causation. And related to that is the question of specific causation. So the question that needs to be, and there are two distinct questions, and it's important that the distinction be made. So on the first topic of general causation, is there a link between the disease and the exposures generally? And then on the specific causation, is there a link between this worker's disease and his or her exposures? They're two very different questions. The first one can be answered by epidemiology. The second one, you need to create, this is why you need to create a detailed occupational history to be able to kind of drill down into that. Sorry, I'm feeling a little bit scattered with like two screens going on. Okay, so the question of establishing general causation. Sorry, 1 second here. So what I've done over the next few slides is I'm just highlighting some resources that can help answer that question. And as I said, so the question is there a link between the disease and the worker's exposure generally? And it's really important to ask the right question. So, for example, I was working on a claim recently where a pipe fitter was working in a pulp mill and developed a particular type of cancer. So when work was done to evaluate was there an association, what was looked at were pulp mill workers at higher risk of this particular cancer. Instead of looking at and drilling down into what was that worker exposed to, what were his tasks, and what was he exposed to, and were there particular exposures that he had that were linked to the particular disease that he had. So that's critical. The one source of information are the IARC monographs. There's over 1,000 agents that they have evaluated, and over 400 have been identified as either known carcinogens, probable carcinogens, or possible carcinogens. So a great resource. They can be pretty dense to read. They're long, but they also have each of the monographs has a really good summary of exposure, and they in some cases have done meta-analyses on individual studies of exposure. The second resource is CAREX Canada. They have, hoping most of you guys are familiar with that. It's CAREX, for those of you who aren't familiar with it, is a repository of information about Canadians' exposure to occupational or environmental carcinogens. It includes, I've just done a couple of screenshots just to give you a sense of the kind of information that's there. So on the substance profile for asbestos, you can sort of get a sense that there's information about the carcinogen itself. That would include things like the main uses, what the exposure limits are here as well as elsewhere. And there's also information on occupational and environmental estimates of prevalence of exposure. So again, a really good resource. They've also synthesized a lot of the other available information that's out there. So a number of the claims that I have advised on have come about because people have gone to CAREX and have been looking for information and then have asked them for help, and then they've been referred to me. The other resource, Canadian resource, is the Occupational Cancer Research Centre. And there's a couple of things that they've been doing. First, this is a table from the Occupational Disease Surveillance System. And again, just looking at their mesothelioma results, they have analyzed it looking at kind of the risks by industry. This is in Ontario, but by industry, and then within industry, sort of breaking it down to particular trades. And so it gives you information about the elevation of risk, and also there's also information that tells you something about the what's the word I'm looking for, about the nature of that risk. These are two screenshots from, or two figures from the report that's coming out on Monday. And this is looking at the burden of cancer in Canada report. They have broken down, this one, this was reported by the 13 different carcinogens, and then for each of them there's a great deal of great information, plus these charts are an industry breakdown of the total number of lung cancers and mesothelioma attributed to occupational asbestos exposure, the reference year being 2011, and a provincial breakdown of total lung cancers attributed to occupational exposure to asbestos. Okay, so I wanted to just briefly touch on the role of epidemiology in these claims. Like I said, it can answer that general question, or question of general causation. So, the purpose of epidemiologic studies is to explore whether there's an association between a particular exposure and a particular disease, and that disease can be kind of measured in terms of morbidity or mortality. It's really useful in determining whether the risk of the disease exists in a particular population of workers, but it cannot answer the question of whether an individual worker. So it's a tool in this in this process, but it is not the be all and end all. Where it is helpful, though. So, as I said, it focuses on populations, not individuals. And the goal, in terms of the exposure assessment, is to group subjects with similar exposure levels. But one of the things that it can tell you is, and it can kind of inform the development of the occupational history, or kind of supplementing of the occupational history, is you can learn about how about the exposure. So it's in evaluating the epidemiologic literature. It's important to consider, like, how was exposure assessed? So, for example, what metrics were used? Was it a surrogate of exposure? So, was it a job title? Was it an industry? Was it a department? Was it yes or no exposed? Did they come up with a cumulative measure of exposure? Did they record peak exposures? That kind of thing. Did they record the determinants of exposure? And so, the kinds of things that are really important to have information on, and this can, kind of inform the further refinement of the occupational history that you build for the individual. Is, it can give you information on, did the exposures vary if the work was performed indoors versus outdoors, continuously versus intermittently? Was it mobile, stationary, those kinds of things, whether certain types of personal protective equipment was used, proximity to other workers, proximity to other sources, that kind of thing. In thinking also about the usefulness of the epidemiologic research, it's important to consider whether the methods of exposure assessment were validated, and was there potential for misclassification or bias. So I want to kind of shift gears, and as I said, all of those sources of information are really good for answering that general question about the relationship between a disease and an exposure more generally. To establish specific causation, you have to build a comprehensive occupational history. You need to drill down from the job, or from the workplace to the job, to the specific tasks, and you have to take into account not only the level and duration of exposure, but also how the levels of exposure vary depending on things like how the task is performed, whether the task is performed in isolation or around other workers, and the availability of control measures. So these are the elements that, when I am building an occupational history, I look at. So the first being, and I'm starting with the first being on the left hand at the bottom, and then kind of working around, looking at getting a complete list from ideally the worker, but if the worker is deceased, getting it from a spouse, trying to get as much information on every single workplace that worker worked in, their employers, the jobs that they held, if they have any kind of more detailed information as well. Information on work activities, the specific tasks that they performed, the processes or exposures, whether or not they used protective measures. Did they have access to personal protective equipment? If they did they use it? Were they trained in it? Like those kinds of questions. Where it's available, measurement data is awesome, and it's can be very helpful. But generally, it's not available. And so what I've had to do in some of the claims that I've worked on is go back to the literature and look for analogous situations. So is there anything published in the literature that can help me figure out that this worker in this particular job, so for example, like if it's a job that you think, or type of occupation or industry that would be similar in different places, are there things that you can glean from those studies that can help you at least kind of make an estimate and say, yes, this is kind of transferable information. So here's an example of once having sort of collected that information from the worker, and this is the kind of a way that I would approach setting it up. So kind of a structured way. What was the job title? What company was he employed at, he or she employed at while performing that job? What location, the years that they started, approximate length of time they worked there, and then description of the work activities, and then the process, and then the personal protective equipment. So what this then becomes is a jumping off point for digging in deeper, asking questions from the worker about, so tell me more about what happened, what it looked like, what happened when you were cutting stainless steel in this situation. Did you do it inside? Did you do it outside? That kind of thing. Asking questions around, did they wear, so in this situation, this example, use degreasers to prepare metal surfaces, it got on my hands. Did you wear gloves? Did you not wear gloves? Those kinds of things. One claim that actually the first one that I advised on, and I roped Ed into part of kind of reviewing some of the the job history that the worker had put together, was he had told us, so this was a worker who was diagnosed with mesothelioma, thought that he might have had exposure to asbestos while he was working as a police officer, kind of directing traffic or kind of in Alberta. He was living in Ontario at the time. So I had a bunch of questions. One was, is he entitled to compensation, and should he apply in Alberta versus Ontario? There's an interjurisdictional agreement, and so he applied in Ontario, and had the exposure occurred in Alberta, and he was entitled, he would have been compensated. But in the course of digging and kind of getting him to go back in time, it emerged that he had asbestos exposure as a student, a summer student. And what he had said to me was, I wore a mask. I was okay, I didn't think it was important because I wore a mask. So then I started to ask some questions about, well, tell me what that mask looked like. I sent him a bunch of pictures from the internet and showed him a dust mask. I showed him a face shield. I showed him a double cartridge respirator, an air supplied respirator. And then he came back and said that one, which was the face shield. And then I did it in a fume hood. And so at that point I talked to Ed, and I was like, okay, so he worked in this lab. He said he was in working in a fume hood. What would, given the time period that he would have done that in, would it have been an effective system? So based on that, we then kind of mapped out and created a much deeper picture of what it was that he was exposed to. So a couple of things to think about in the context of, once you get a history like this, or kind of a picture of a job like this, you also want to go back as far back as you can to the first job that they've ever held. And then, depending on what your role is in this, so from my perspective, working from the outside, I don't have access to company records, so I can't go to the company records and corroborate the job history, or whether there were particular tasks that he's performed that he had forgotten, those kinds of things. One of the claims I worked on recently, I was really fortunate, the surviving spouse had requested discovery, had a ridiculous pile of boxes that she was going through, and buried in there was his job history, every single job, it was a card for every single job he'd ever held in his workplace, going back to the 1960s. And so from that, I started to be able to piece together and come up with a better picture of what his jobs and tasks were. If there are job histories available and you have access to them, do they tell you anything about where the individual worked? Do they supplement and corroborate what the worker has told you? And are there long-term workers available for interview? That's actually been quite critical for a couple of the claims I've worked on. And one in particular where I had gone through and read the job histories and mapped out and actually had gone back. It's just a claim for a worker in a pulp mill. Had gone back to data that George and I were involved in. George did all the work, but a study that George and I were involved with at the BC Cancer Agency, where he had created these really detailed job exposure matrices. And so I went in and I pulled out the particular types of exposures that he might have had. But what we didn't catch at that time was that there was a particular task that was being performed really intermittently. And this particular job title had, they were cycling through every 6 weeks, and he would have had exposure to the potential causative agent during that exposure. So in that situation, it came up because I was just sitting and having a conversation with his widow and 2 of his coworkers, and in the course of them describing what they did on a day-to-day basis, they happened to mention this intermittent exposure, and then that was kind of the jumping off point for then going into a very deep dive into looking at the likely duration of his exposure and the extent of his exposure. The only other thing I wanted to comment on in relation to this is if a worker is filling this out and kind of starts out with like a very generic job title. So, for example, in a pulp mill, if a worker says, "I was an operator," there are a lot of operators in a pulp mill and in many other industrial facilities as well. So job titles don't tell you much other than the job title. They don't tell you anything about exposure. You could have individuals with the same job title doing different tasks, exposed to different agents, and being exposed to different exposure levels. So it's really important to kind of go beyond just the job title and to get as specific information as possible. So once you've kind of got that initial sense of what the worker did, then the next step is I start to explore themes of exposure. So there's 4 key questions. The first being how much exposure, and this is just more of a descriptive, getting at, kind of having a conversation with the worker or coworkers, and just getting as much descriptive information. So there's some examples here. One being dust was visible in the air, and that equipment was coated with dust at the end of the day, or small fragments of material fell down onto my face and arms while scraping insulation off pipes. That gives you a pretty good clue that maybe they were exposed to asbestos. And then the next question to explore is how were they exposed? So was there exposure by inhalation? Was there the potential for dermal exposure? Did the workplace or workplaces, depending on how many jobs they held, was there ventilation? Was it local? Was it general? Did they have access to personal protective equipment? Was there the potential for exposure through other routes of exposure as well? And then it's also important to think about kind of trying to get at an estimate of duration of exposure. So the other 2 questions kind of help you kind of move down that path towards estimating, kind of coming up with an estimate of level of exposure. But then it's important to explore the themes around like how long did the exposures last? If you can get information from the worker themselves about, get them to estimate, on an average day, how frequently were you exposed, or how, for what period of time were you exposed? And then were those repeat exposures, and have them estimate, so, look at it from a day, look at it over a week, look at it over a month. And then try to come up with some quantitative or semi-quantitative assessment of what that looked like. So, for example, this is a potential exposure for a heavy-duty mechanic to benzene. Could have had exposure by inhalation for 2 hours a day, 3 days a week for 12 years. So that helps you come up with an estimate of exposure. And then the other thing to think about is was there non-occupational exposure to carcinogens? So for example, they smoked cigarettes from the age of 15 to 45. They smoked 2 packs a day. They quit at age 45. Those are really important clues in terms of what other exposures they might have had. And actually, one thing I just want to comment on, because I didn't when I was talking about the legal test of causation. In BC, the legal test is it's whether or not the exposures had causative significance. So were they a significant contributing factor? They don't have to be the only cause or the dominant cause. So it doesn't preclude workers who smoked from getting being entitled to compensation. That was the one point I wanted to make about this. Okay, so this is also kind of for any practitioners who are working in industry who are online, this is also a bit of a plea for availability of or collection of data. So the other question that I look at is, are there measurement data? So if there are, looking at whether or not it's current or historical. So current measurement data tells me something about today. It tells me something about the current, the levels that they're exposed to today in the context of the conditions within the workplace. If you have information on how a particular workplace has changed over time, then you can start going back and adjusting, what those current levels are to come up with estimates of historical exposure. Some other questions are, was it continuous or intermittent? Was it taken for regulatory purposes to demonstrate compliance with the regs? Is it for the agent of interest? That's an important one. And then also, is there information that's recorded on them, like about the determinants of exposure or how the samples were taken or analyzed? And then if there aren't data available, kind of going back to that very far right-hand side of that, building that figure where I was showing how to build an occupational history, which is looking at analogous situations. So are there data available in the literature? In a couple of claims, I have found it very helpful to go to NIOSH health hazard evaluations. One in particular was a worker who was exposed to asbestos in actually brake repair, and there was some resistance to kind of acknowledging that this particular worker had asbestos exposure, and I went to historical reports from NIOSH dating from that period of exposure in the 1970s to say, automotive repair is not that different depending on where you are, and so it's more likely that he would have had exposure in this range. And then, as I said earlier, the IARC monographs are also a really good source of information on measured exposure levels. So the next thing that I do, or one of the things I do kind of as part of this process, and this comes from me being a very visual person, is, and you don't really want to come to my apartment when I'm working on these claims, because I really love those giant Post-it notes, the easel-sized Post-it notes, and they're all over my apartment. So basically what I do is build a timeline and kind of lay out kind of the timeline from the start of the first job through to the most recent job, and then start laying onto it, the occupational, were there practice changes, regulatory changes, technological changes, anything that's going to impact on the exposure. And then on the flip side, I also add on some of the personal kind of lifetime kind of experiences or points that are important. Like, so for example, started smoking when you were 15 and then quit when you're 45. And where that kind of aligns up in relation to the diagnosis. And then finally, organizing the information in a coherent way. So for each of the jobs, laying it out, again, how I described earlier with the company, the year, the duration, the specific work activities, flagging which ones were the important exposures, and then synthesizing all of that information about those themes of exposure, how much, how long, how, non-occupational exposure potential, and then flagging if there's anything that I need to go into to get additional information to kind of put together a report that I would then give to the worker to support his or her claim that would go into the workers' compensation or their lawyer if they're kind of at an appeal stage. And this is my final slide. Just wanted to flag 3 takeaways. One is that it's really important to understand the system. So it's important to understand how claims are adjudicated and whose role it is to adjudicate them. When I first started doing this work, and I worked at the BC Cancer Agency, we used to get questions all the time. Like we would get either from doctors or from patients saying, I've got this cancer, is it work-related? And I will confess, and I'm not particularly proud of this, that I didn't understand how the system worked. And over the years, it's been my experience that there are a lot of people who don't understand how the system works. And so when people get that question, sometimes they're like, and in that situation, I did a very quick review of the epidemiological literature and came back and said, no, your cancer is not work-related. But that wasn't my job. That wasn't my role. My role was to help, kind of look at what the literature said around general causation and then say, you may or may not have had the exposures, you should file a claim, because the role of adjudication rests with people, the case managers at workers' comp. The other important takeaway is that there is to remember that the important distinction between general and specific causation. Epidemiology can answer that first question, but it can't answer the second. It shouldn't be used to adjudicate claims. You have to build comprehensive exposure history, and if you don't have quantitative data, build it with estimates based on descriptive information, and then try to kind of build in, with analogous situations, a way to make it quantitative or semi-quantitative as best you can. And last, I just want to say thank you to you guys for your attention and bearing with me while I jump back and forth between these. And then I just want to acknowledge Paul Demers at the Occupational Cancer Research Center, who graciously let me use some of those figures from a report that's not yet published. CAREX Canada for having referred a number of these claims to me, and their data as well. And then the AWCBC and the Cancer Society are where I source data. And then finally, I just want to acknowledge Kay and Ralph, both of whom were and or are affiliated with SPPH. They approached me back in 2000 with a document that was designed to help train adjudicators on how to take an occupational history. And it's based on that information, like based on that structure and the approach that they took, that systematic approach, that I have built the approach that I use. So with that, I thank you.
Thank you very much for your presentation. It was very interesting. I'm sure that everybody here enjoyed the overview. We're going to keep juggling.
Okay.
Doing mics. So, answering questions. And I'll ask you to actually put down some of the audience for our online listeners.
So for the online audience, the question was, what can we do to systematize this approach and make it more widely accessible and usable? Does that capture what? Okay. Well, one thing that is going to be done. So I had spoken in the context of a CAREX webinar on this issue where they had illustrated 3 case studies It was organized by a group in Ontario, and they had illustrated kind of how claims are adjudicated and where some of the challenges are in the context of the Ontario system. And then I kind of gave a very high-level synthesis of kind of what the key messages were. And what we have talked about was taking the approach and the document that I have been working from and updating Kay and Ralph's work to make it available via CAREX. The other thing that I would think is important, and I didn't really have time to touch on it, is like sort of thinking about that question around like why we aren't seeing the claims in the system. There's a kind of a host of factors. One being, workers aren't filing. Why aren't they filing? Are they not filing because they don't know that their exposure or their work may have been related? And is that because physicians don't know? So I think that reaching out and educating physicians would be one thing that could be done, either through continuing education, partnering with WorkSafe and other WCBs. I am actually currently working on a report with Paul Damaris at the OCRC. He's been asked by the Ministry of Labor to look at how occupational disease claims are adjudicated there, and then kind of looking at it in the context of other jurisdictions. So perhaps we can also get the word out as part of that as well. Does that answer your question?
Yeah.
I think an app would be great. I said, I think an app would be great. Yeah. And I think actually, another thing is just data, like having a queryable database, like perhaps the CWED, the Canadian Workplace Exposure Database, if we were able to make that queryable. But in terms of like getting this particular approach out, I would say the starting point is via CAREX.
There is a lot of interest from our audience about the webinar that you mentioned. Do you mind, again, specifying where to get the information and what it is going to be about?
Sure. I will need that back, though. I'm actually going to look it up very quickly. You want to give me that back? Okay, so I actually had forwarded the information to Karen. Are you still running the impactor? Yeah, so let me just very quickly. So this, it is being hosted by the Occupational Cancer Research Center. It will be available via webinar. I can resend the email if you want. It is Catherine Lapel who will be presenting. It's Friday, September 27th, 12:30 to 1:30 p.m. Eastern. And what she's going to do is provide the basic building blocks for understanding rules and processes governing the recognition of occupational diseases in the context of workers' comp legislation in Canada. She's drawing examples from Ontario, BC, and Quebec to illustrate ways in which scientific data is used in the adjudication process and mechanisms by which decisions are made in individual cases. Participants will learn the importance of acknowledging specificities of medico-legal adjudication in the context of workers' comp claims in light of the underpinnings of workers' comp legislation in Canadian jurisdictions. So you can register for that online.
I'll take a second to relay the big thank you from everyone on our online audience, and we actually are running out of time. So please help me thank Anya for her presentation today. It was a pleasure having you.